Welcome to the Washington Medical Commission webinar series. Today we are looking at the University of Washington and their study of COVID-19 presence to inform smart policy decisions. Today we are honored to have Dr. Keith Jerome with us. Dr. Jerome is a physician and medical researcher on the faculty at the University of Washington and the Fred Hutchinson Cancer Research Center. Dr. Jerome leads the virology division within the Department of Laboratory Medicine and Pathology at the University of Washington. UW has been a leader in the national response to COVID-19, providing clinical testing and support for research studies evaluating new therapies and vaccine candidates. Before I turn the webinar over to Dr. Jerome, I would like to take care of a few housekeeping items. All participants will be muted for this webinar, but please use the question and chat functions to ask your questions. At the end of the presentation, we will have time for Q&A. The presentation slides, recording, and CME evaluation will be available on the webinar website at the conclusion of this presentation. The webinar is accredited for 1 hour of Category 1 CME by the Federation of State Medical Boards. If you are watching in a group setting, please make sure you register for the webinar and complete the evaluation as an individual to receive CME credit. A link to the post-webinar evaluation will be emailed to you after the presentation. Please complete this evaluation within the next 2 weeks to receive CME credit. The evaluation link will also be available on the webinar webpage. This webinar is not funded by any commercial entity. The speakers, course director, and planners at the Federation of State Medical Boards and the Washington Medical Commission have nothing to disclose. Now, with all of that out of the way, I will turn it over to Dr. Jerome.
Great, thanks so much, Jimmy. Are my slides up?
I see them.
Perfect, thank you. Well, it's a pleasure to get to speak with all of you today and talk a little bit about what's going on at the University of Washington Virology Division. I'd like to take the next 45 minutes or so. First of all, just telling you a little bit about giving you kind of an update of what we've been doing, what our response has been to the pandemic, what's going on now, just for perspective. And then focus more specifically down on our serologic testing, including this statewide community sero survey that's been funded by the Paul G. Allen Family Foundation, and tell you about how that's going to be working and where all of that stands. And there we go. So I think I don't need to spend too much time telling this group about SARS coronavirus 2. I think you're probably all aware that there's a number of coronaviruses that we've been dealing with for millennia. These are the endemic coronaviruses that you see here. And essentially they cause the common cold. Yet there are some severe coronaviruses. We all know about the original SARS coronavirus from 2003, as well as the Middle Eastern Respiratory Syndrome, both of which are very severe diseases with high mortality rates. And in fact, if there's a silver lining in what we've seen so far with SARS-CoV-2 is the lower mortality rate. These are all RNA viruses, and they're actually big RNA viruses. RNA viruses typically have a couple of thousand to maybe 10,000 base pairs in their genome. This virus has 30,000, so it's getting into the range more typically associated with the DNA virus. And because the genome is so big, the virus has actually been obligated to have a proofreading enzyme. It checks its RNA as it replicates, makes sure that the replication is happening with high fidelity. And the bottom line of why this really matters is it means that the mutation rate of the virus is relatively low compared to something like HIV or influenza and so forth. In fact, the mutation rate of this virus is almost in a sweet spot, that its rate is slow enough that we haven't seen much change in terms of changes in pathogenesis. There's been one mutation that seems to make the virus a bit more infectious, more easily transmissible. But the virus does mutate quickly enough that we can actually trace it from one person to another. I'll show you a little bit of data that we've done about that. For purposes of the serologic testing, the virus makes 4 structural proteins. Most of the testing actually will be looking for antibodies to the nucleocapsid. That's the little protein here in these little light blue circles that surrounds the viral nucleic acid. It's a great target for immunologic assays because the virus makes a lot of this protein, so it's a very strong immune response to that. But if we want to actually stop the virus from infecting new cells, we look for antibodies to the spike here on the surface. That's what makes these kind of protrusions from the surface of the virus that give it its name as a coronavirus. And of course, we all know that SARS-CoV-2 is the cause of COVID-19. I'm sure you guys keep up with these sorts of figures. The national maps are really quite disturbing now. There are numerous counties throughout the country that are having more than one case per 1,000 people reported per week or per day. Really quite shocking. We've been fortunate here in Western Washington and Washington as a state that we have, in general, been able to contain our pandemic somewhat more effectively. Certainly not as well as we'd like, but our rates have been lower. And so, if you look at just the total number of cases, we have been substantially lower than the eastern and southeastern parts of the United States. So, I want to make the point. I get asked a lot. You know, what have we learned from this? What do we have? How can we prevent this from ever happening again, assuming we get past this? And, you know, one thing I do want you guys to appreciate is we actually have the capability to find a new pandemic, even if it starts right here. And that's because we have a large metagenomic sequencing effort, which means we can take samples that come in for clinical syndromes and actually just sequence them very, very deeply and look for any sequences that look like any known viruses. So, in fact, we took some of our early samples that we got very early in this pandemic and put them through our metagenomic pipeline just to say, look, if we didn't know anything about SARS-CoV-2, could we have found it? And the answer is yes. These are really low numbers. I mean, this is, you know, UW case 1 through 6 or so. And in fact, all of them we find through our metagenomic pipeline, and they get identified as a SARS coronavirus-like virus, now known to be SARS-CoV-2. We'd have a really good idea of what it is and would be able to share that with anyone else. You can also find whatever else is there. So sometimes there's bacterial commensals like Moraxella. And early on in the pandemic, people had co-infections. So you could see some of our folks actually had, here's a patient who had parainfluenza virus as well. And then some people who were actually negative, we could identify what they did have, which was a rhinovirus. So we actually are prepared should something like this come again. And if we were truly globally ground zero, not just nationally, we'd be able to respond rapidly. So we got these early genomes, and in fact, we were able to work with colleagues at the Fred Hutch and elsewhere to really identify that this was a local outbreak here. There was community transmission. We were able to start to build these phylogenetic trees that you've probably seen many times. And this really told us a lot about how they've transmitted. This is a paper that we've published now, been published in Science. And you can see that we had these kind of a major and minor clade that came here in Washington. And this was really our major clade that could trace back to a single common ancestor. We were able to identify that we shared the virus with our colleagues down in California. You might remember one of the cruise boats cruise ships that was down there, and it looks like some of that was interspersed with the Washington case. I think it's here. Some of the community cases as well were related to Washington. So the virus did begin to spread from Washington. But in fact, when we worked with our colleagues on the East Coast, what we found is that, yeah, we sent a little bit of virus their way. This is from a colleague in Yale, and you can see some of our Washington isolates were co-mingled with this. But in fact, it turned out very rapidly that those kind of Washington or West Coast strains were very rapidly overwhelmed by a big influx of virus coming from Europe, and that's become the predominant strain circulating throughout the United States now. So we were kind of confronted with this problem early on about testing, and I think you remember all the issues around testing. And you know, this is a kind of an opinion piece that we put out really early on, really identifying some of the issues we saw around diagnostics. And it's kind of sobering to say that 10 months later, a lot of these issues are still there, that you have this really large population at risk. Many of them don't have access to testing. Even the people who do, not that many get the test. And even we still hear these horror stories about delayed testing, taking days to get results. How many people actually get them in an actionable time? So it's been a real issue, and it continues to be. We were, of course, very early in the preparation for this virus. We made the decision in early January to start to prepare and develop our own test. Of course, we were not allowed to use it for a while because of the need for an emergency use authorization. That was a fairly stringent process through the month of February, which we were not able to complete before the virus got here. And then, of course, we got the green light once some of the regulatory requirements were relaxed a bit. And so we were testing by really the beginning of March. I just want to highlight how much work went into that, and really to put a focus on the staff in the lab, because there were incredible number of late nights really developing these assays, validating their use, showing that they worked well, and then putting them into application, and then getting this data out there, publishing it, putting it on bioRxiv and medRxiv, and ultimately in the peer-reviewed journals, so that other laboratories could make use of our experience. And so that was a real tribute to the folks in the lab who did that. One of the contributions we made early on was dispel the myth that PCR testing wasn't very good. There was a thought for a while that there were a lot of false negatives. We did a study together with colleagues at Stanford. Actually, their laboratory director is a former trainee of ours. It identified that actually, if you just looked at people who got a negative, these were symptomatic folks that came into either Stanford or UW with symptoms, were worried about SARS-CoV-2, got a negative. How many people actually then got a positive test within a week? So, was that first one negative and now they're positive? It was actually very rare, less than 3%. And of course, some of these folks just got exposed to virus subsequently. And we also know that now you can have a negative result very early in the clinical course, particularly in the pre-symptomatic stage. So we've really learned a lot about how to interpret these tests. And all this data then has really gone into really quite effective public health response in our state that I mentioned already. This was a paper that we published early on in JAMA, just showing that the combination of rapid access to high quality testing together with effective interventions at the state level really did flatten the curve. So you can see this is our positivity rate in various groups. So these are our Washington State outpatients, Seattle outpatients, and then our ED patients. So you can see, we had certain days where we were even above 15% positivity rate, even though we were doing quite a number of tests. We were able to knock that rate down. And that rate's actually stayed down. It did extrapolate down into the 1% and 2% for a while. Of course, we've had additional waves, as you know, and we're in a third wave now. Our positivity rate, you'll see, I'll show you now, but it's pushing 5% again, unfortunately. So we're not moving in the right direction, but we have flattened the curve past where it might have been. The other thing I want to mention, about the last thing about the PCR testing, we were, I think, the first laboratory actually in the country to begin to do sample pooling for clinical testing. So we identified sites where we got testing that had low percentage positivity rates. So things like the City of Seattle sites, for example. A relatively small proportion of those were actually positive. So we were able to do 4-to-1 pools. We actually take 4 samples, put them all together, test that pool. If it's negative, everybody gets a negative result. If it's positive, you go back at those primary samples and test them individually. And this has really allowed us to do a lot more testing in a very effective way and get results back to people very soon. We actually didn't make a lot of news for doing this because our pooling was actually done through a state of Washington emergency use authorization. You might know that the FDA has delegated authority to our state DOH to provide us emergency use authorizations. So it didn't make the national news, but we were actually the first ones, and we've been doing that, gosh, for several months now. But of course, we're not done. You can see here our positivity rate as of yesterday. Yesterday's testing was 4.9%. That is above our average overall. And I'll just point out, we have tested over 1 million samples so far. And this is not anything we ever dreamed we would be doing in our laboratory. The laboratory and the program's grown tremendously with new people, new instrumentation. just new responsibilities, and it's really been a tremendous effort. I'm incredibly proud of the work that our division and staff have been able to do. So let's turn to serologic testing, which will lead us into the sero survey. That's sort of the main topic of today's talk. Of course, the PCR tests tell us if a person is infected now. Serologic testing looks for the antibody response, the immune response to an infection, and that response is durable, at least for a while. And so you're actually looking at a historical view of whether someone has been infected in the past. And this is helpful because we can do things like a population-based study of seroprevalence. We can identify what proportion of people in a given area, a given population, have actually had COVID at some point in the past. And that may be helpful in terms of thinking about public health policy recommendations, decisions about opening, closure, restrictions, availability of vaccines, targeted populations, and so forth. Generally, we don't think about using serology in primary diagnosis. That really should be done by PCR. A few people have argued that in certain circumstances it may be useful. It's really not the point of it. And then, of course, people really, want to know, what's my risk, right? Can I go back to work? These sorts of things. And now, obviously, we're starting to understand the correlation a bit better between antibodies and protection. And in fact, the first evidence of protection I'll actually show you came from some folks in our group. But I think we're starting to get this sense that these antibodies actually are useful, which is great news because antibodies, as you probably know, are being developed as therapeutics. And of course, the vaccines that we're also excited about also will be generating these antibodies. So when we think about a serologic assay that we'd like to do for SARS-CoV-2, we want a couple of things. First of all, we want to have good sensitivity. So if someone has been exposed to SARS-CoV-2, have had COVID, we want the test to say, yep, they've got these antibodies. Maybe even more important, we want it to be highly specific. We don't want there to be false positives. False positive results in this could be used for ill in several ways. They can be used to exaggerate how many people in a community have actually already had it. So it could make people think that we're closer to herd immunity than we actually are. They can also lead to bad decisions in terms of individuals' risk. So we need to have good sensitivity and specificity. We really need to correlate these assays with something, a marker of meaningful immunity that is, do these tests actually measure something that correlates with actual protection from infection? And then, of course, just in a practical sense, it has to be high throughput. It has to be able to run it on the instruments that we have and so forth. And so we did one of the really early studies evaluating a SARS-CoV-2 IgG assay from Abbott Labs. You might remember that through the late spring, there were a number of serologic tests that were made available that really didn't meet the criteria that I mentioned. They performed very poorly. There were a fair number of false positives, and this is a real problem when we look at populations who probably have a low prevalence, a low expected prevalence of SARS seropositivity. If the test even has a few % false positives, in fact, most of the positives you find will be negative, or most of the positives you find will be false. And so we really needed a highly specific test. And so we were excited about this. We had run a number of Abbott assays in the past, and they've generally performed quite well. This happened to work on an analyzer that we had that's high throughput. Each one of those can do 3,000 or more samples a day, and they're really around the country. So we wanted to evaluate this independently of what the manufacturer had done. And so we did a study where we looked at 125 University of Washington medicine patients who'd been hospitalized for SARS-CoV-2 and just evaluated their sera via this test. And in fact, so what this test actually generates is an index value. So somebody who's never been exposed to COVID will have typically an index value down here closer to 0, below this red line, which is the manufacturer's determined level of positivity. if you look at people who come in and have been hospitalized, you can see that on early days after symptom onset, maybe the majority of folks are actually negative. They haven't developed these antibodies yet. But then as the symptoms go on, more and more people become positive. And you can actually plot this out as a function of either symptom onset or PCR, the first positive PCR test. And you can see that within about 2 weeks, the vast majority of people become positive by this assay, and actually by 17 days, every single person is positive. The test is also highly specific. We were very interested in this. We're a reference laboratory worldwide for herpes simplex virus serology. We run the gold standard test that all others are compared to. And so we had a cohort of over 1,000 samples that have been sent to us over the past year, but before there was COVID. And so we ran these 1,000 and actually found a single sample that was 1/100th of an index value above the cutoff. So that gave us a specificity of 99.9. And in fact, if we set our own cutoffs anywhere between 1.42 and 1.49, we actually had a perfect receiver operating curve, that perfect sensitivity and perfect specificity after 17 days. So really highly performing test, and really the first commercially available high throughput test that we could actually offer anywhere that could provide the serologic insight. Test actually is kind of semi-quantitative. You can actually watch, we'll just focus here on panel B, you can actually watch patients seroconvert. So they'll start off negative, as I mentioned. You can watch a given individual go from seronegative to seropositive. And in fact, these slopes can be really quite steep as people develop these antibodies. So I mentioned this idea, you have this test, measures these antibodies, it measures antibodies to nucleocapsid. We know that nucleocapsid can't neutralize. And furthermore, when we started this, no one had any idea if antibodies were actually protected. We assumed the answer would be yes, but we didn't know. And so Alex Greninger in our group actually had a great insight that these fishing vessels that are many based here in Seattle, and they go out and it's a crowded situation. This group of people is going to be together working very long hours in crowded situations. It's a real place where you'd worry about COVID-19. So we'd been counseling these folks on how they might do testing strategies to prevent these outbreaks. And unfortunately, this particular ship actually had an outbreak despite some efforts to screen the crew. And so we were able to get the serum from this group, and we actually found that although about 85% of the folks who were on the ship actually got COVID, there were 3 people on the ship who actually had not just antibodies, but neutralizing antibodies. And you have to do a much more complicated test to find out if they're neutralizing. But of those 3 people who had neutralizing antibodies, none of them actually got infected. And although, it was a relatively small crew of, not much over 100 folks, and only 3 fit in this group, this was actually highly statistically significant. So it was the first formal demonstration that antibodies are actually protective. And this has now been confirmed by a number of groups. So we have this test. Of course, one major use of serologic testing would be to do these sero surveys. And so we worked with a group in Boise, Idaho called Crush the Curve to do a sero survey there in a pretty thrown together fashion, quite frankly. So, we could offer the testing. This group was pretty savvy in terms of social media and public outreach, and basically just let people know around Boise, hey, if you're interested, you can come and participate in this study. So obviously the people who would come to this are highly self-selected, not clear that they really represented Idaho, but we did this in late April, so it got done very, very quickly. And you can see that we found a positivity rate, depending on the group, but overall, around 2% of people who participated were actually positive. And the rate looked relatively flat across ages with some bumps, largely, I think, just because the sample size is relatively small. So maybe about 2% of people in Idaho and Boise, at least who participated in this study, already had antibodies already been exposed. Now, obviously, if you thought you'd you might be more likely to participate in this if you thought maybe you had COVID earlier in the winter. So there's self-selection. So does this really represent what was going on there? Who really knows? We continue to do this test in routine operations. This is a little bit out of date in terms of the total number of samples done, but this number hasn't changed too much. We've always been around this 4 to 5% positivity rate. And again, people who actually request this testing are often a self-selected population. So what else have we done? We've continued to test patients who come into UW Medicine for other things. So if they're interested and want this, we can test them. So those folks we see, here's 5.8%. We did a study together with Fred Hutch. This is a return to work study. Fred Hutch essentially closed down early in the pandemic, told everybody to stay away, and then very slowly opened back up at a very reduced level. And so as employees came back, a subset were selected randomly to participate in a study, and we swabbed them. They got serologic testing. And of 481 that we tested, only 6 were actually positive for antibodies, so a little bit lower maybe than what we might have expected in the general population. Again, not necessarily a representative population. Fred Hutch employees are generally fairly well educated. We're probably pretty careful, and of course their workplace was closed down, so a lot of reasons to think this might be lower than the population as a whole. And then we've been studying UW Medicine employees, and sort of the take-home message of this is that the prevalence of seropositivity in UW Medicine employees tends to be lower than the population as a whole that we've tested, and we believe that the real take-home message of that is that the PPE and the precautions that have been taken to keep our staff safe have generally been working. There's no evidence that our employees are getting COVID-19 in the workplace, and so that's been very encouraging. But really, none of these studies really represent Washington State as a whole, nor do they tell us anything about where the virus is and how it might differ in the way it's affected various regions of our state or various racial and ethnic groups. So we were fortunate to be able to work with the Paul G. Allen Family Foundation to conceive this Washington seroprevalence study. And what that is a study of 8,000 participants. Everyone will get an initial PCR test for virus. So we'll get one snapshot here at the very beginning of this study of who's infected right now, and then serologic testing for their past exposure to the virus. Then with follow-up serologies, approximately 2 and then approximately 4 months later. In addition, anyone who's part of the study and wants and has COVID-like symptoms, we will encourage to get PCR testing, and we'll provide that for them upon request. I'll go a little bit more later into the specifics of how we're doing this, but it will be this kind of address-based household sampling done by field teams that are being organized by the University of Washington. We've selected counties in a way that I'll show you to really try to represent the diversity geographically of the state. And then we want to make sure that we have statistically robust data for racial and ethnic subgroups. And we'll talk about our thought process behind that, some of the considerations, and how we're going to do that. So the main objective here is really to estimate the prevalence of COVID-19 in Washington State, as I mentioned, both by PCR and serologies. As a corollary of that, we will get some estimate of COVID-19 prevalence at the county level within participating counties. For reasons that I'll show you, because of sample size, there will be more uncertainty around those estimates. And then we want to estimate the prevalence between underrepresented groups, again, the Hispanic, Latinx community, African American community, and the American Indian Native American community. These are ones based on initial look at population sizes. We were concerned that they might be underrepresented in our overall sample. There are secondary objectives to the trial as well. We're very interested in the temporal trend for seropositivity over time. We would expect, because again, we're in a third wave now, and we don't know how many waves we're going to see of this infection, We expect seropositivity to grow over time. As the flip side, we still don't have a full understanding of the decay of antibody positivity over time. There clearly is a decay quantitatively of virus or of antibody over time. We will try to understand the kinetics of that within our participants, and then try to overlay that against our overall temporal trend. And then we would like to look at what factors within this immune response are actually associated with COVID-19. So here's the county layout of Washington State. You guys have all seen maps like this, and this is just based on population size. The lightest colors are the most populous counties in the state. And so if we have this state with all these counties and we have a specific amount of resources to perform this study, where we want to represent the state as a whole, how do we deal with that tension of the reality of getting these samples versus this tremendous diversity? And so in collaboration and consultation with representatives of the Washington State Department of Health, as well as the Paul G. Allen Foundation, we first of all identified a number of counties that were considered hotspots or counties of special health interest that were identified and placed into the study. And those are illustrated in red here. So you see the populous counties here of Western Washington, areas that have had known hotspots, Spokane. It's not actually incorrectly not colored. Clark County is actually included in that rationally selected group of counties because of its proximity to Portland urban area and its unique characteristics in terms of the pandemic being driven largely by out-of-state transmission. So those counties were included in this. Together, they represent nearly 80% of the population of the state. And so we already felt like we were going to get a reasonable understanding of the state as a whole. Then to try to get a representative selection of the remaining counties, we divided the remaining counties into sort of a Western group and an Eastern group. We stratified them into tertiles by population size. So the most populous, the intermediate, and the least populous counties of those states. And each of those groups got a lottery in the west and the east part of the state, giving us 3 more counties, 3 in the western part, 3 in the east, that were selected to participate. And those are shown here in blue. So it's Island, Jefferson, Thurston were randomly selected for Western Washington, Douglas, Grant, and Pend Oreille for the eastern part of the state. And then I mentioned we have originally thought about we would have 6,000 for this. We have identified some efficiencies and be able, we hope to actually perform 8,000 tests and have 8,000 participants now. How are those distributed throughout the state? And there's sort of 2 extremes. You can think that they should be distributed exclusively by the population size of those participating counties. So King County should get more because it's big, and maybe Pend Oreille should get fewer because it's small. The other way to do it would be to say everybody gets the same amount. And there, of course, you get very, very precise or relative oversampling for the less populous counties. So we actually took a hybrid approach, working with our statistical team, Dr. Olivier Hirian from the Fred Hutch, to identify a minimal number of samples that a county needs to get a statistically valid look. And those are arbitrarily chosen confidence intervals on that, but 300 samples is a nice selection that you're kind of getting into the sweet spot that it becomes progressively more difficult to pull down those uncertainty intervals. So each county gets a minimum of 300, and then the remaining, once all of our participating counties each get 3,000, the remaining sample slots are then distributed by population. Now, I mentioned we're very interested in racial and ethnic disparities among the COVID-19 impact. And I know you guys have all seen this from the DOH website. And so we know that COVID-19 has had a disparate impact. If you look at the percentage of population versus COVID, you can see some populations have been overrepresented in terms of diagnosed cases. Here, Hispanic citizens of our state. You see similar sorts of data for hospitalization. Interestingly, and I'd love to talk with you, some those of you who thought more about this, but we're not seeing that in terms of death rates, and I don't understand if that's due to reporting issues or actually something that is an accurate reflection of the real state. So then, where are these populations of interest relative to the counties that we want to sample? And because we're looking at the most populous counties in Western Washington, our African American population tends to be overrepresented in those. And in fact, we were able to calculate statistically that in our baseline sampling, we expect to have a complete representation or a statistically valid representation of our African American community. That's true for the Asian community as well. It's true, it appears likely to be true for the Hispanic community. We will watch that through the trial as it moves forward in terms of our actual enrollment rates, and we will oversample if need be for that group. For the American Indian Alaska Native population, it's clear from the beginning we're going to need to do some oversampling, and I'll talk a little bit about some of our outreach for that, how we hope to address that. We really want to partner with local health jurisdictions. We really need some partnership for this, and we've had a number of discussions, maybe some of the folks on this call. The public health entities on the local level can really provide us some support. The local context for our testing. How will a cold contact from the University of Washington be perceived? And that may not be the same in all parts of the state. Then, we want to come and we want to take your blood and we want to test you for COVID. Response rates may vary. Just level of trust in the research enterprise may be different. So local context is going to be very important. The public health entities can make sure that we're talking to the right folks locally with theirs. They can help us with outreach. If there's the ability to get the word out, this is happening, some interest, that may help drive our participation rates as well. But ideally, we'd love to have some partnership, and we're making some progress. Some of the counties there, can you provide a little bit of help at times, just human help, so that our UW field teams are not overburdened trying to do this. We're going to, this is going to be a real challenge for them. How do we get the results back to participants? One thing we really want to do is provide some value for the people who do choose to participate, so they'll get a sense of their own serostatus and how that changes over time, and their PCR testing, help in making sure we get that back in an effective way. I will mention just in passing, we're well aware and we regret that we're not able to include every county in the state. It was clear that that would not work in the resources that we've been provided. Counties that were not selected in the lottery to participate or that weren't the predefined counties, we're certainly happy to work with them in other contexts. And our laboratory is certainly open. So if we can, find resources to do testing, we're happy to talk about ways we can help you, meet your needs for your local population. Cheryl Dietrich, this is her contact information here. She is our project manager. She's doing a fantastic job and has made contact maybe with some of you on this call. So the local counties are working with her a lot and really trying to get together, best practices and identify challenges and technical insights that we can really put this together. Again, we're well cognizant of the special considerations around the Native American and Alaskan Native communities. And so we've already reached out to a number of tribal leaders. We've had a number of discussions with American Indian Health Commission, other folks who work with these populations, and I'll hit on this just a bit more in a minute. So methodologically, the survey is really focused on the county as the primary sampling unit. We talked about that. And then within the counties, we'll be looking at individual census tracts. Once we get within the census tract, then it's essentially a cluster-based household survey. So Of course, the number of census tracts vary between counties. So counties that have 8 or fewer census tracts will be in all of them. If they have more than that, we will sample an appropriate number of census tracts to get the required sample size. Going to focusing on census tracts gives us efficiency of our field teams, so they're hopefully not spending all their time on the road and driving from one place to another. They can actually get locally and make efficient contact with folks. We plan on sampling about 15 households per census tract. Here's just a breakdown of census tracts per county and the number of tracts that we think we need to sample. And here is the sample size. You can see, for example, many of the smaller counties by population will get their 300, whereas a county like Pierce, for example, will get over 600 samples. In fact, I'll say that we're partnered with Pierce through a separate additional source of funding. We'll be expanding this to really try to tighten up local estimates at the county level for Pierce County. They had some interest in that. So just an example of if there's something at your county level you're interested in augmenting this, we can do that, provided there are resources to go beyond what we're able to do through the parent funding. So to some degree, the approach here is modeled a bit after the Casper methodology. Many of you will be familiar with. So again, you sort of have these clusters. In this case, there would be census tracts. You have a number of houses within those. And then field teams basically go to do these household level assessments. Casper is typically questionnaire only. And so there's a number of considerations around that. Of course, this isn't really perfect for Casper, but we are taking a lot of knowledge from their toolkit and their guidance and so forth. So there've been some great resources from that. And one of the considerations is simply that, as I mentioned, our response rate is expected to be different between counties. And so this is the census response rate in different counties. And you can see that we had relatively high response rate in some of the more urbanized parts of the state, less so in others. And so, that's telling us that we may need to focus additional resources into these areas if we want to get a good sample. So here are some of the tribal leadership that we've reached out to. We sent a letter to the leadership of all of these tribes. These are tribes that have that have part of their lands within the counties that we've identified to sample. So within our sample, we expect through our random sampling to select members of these tribes. And so we really want to do that in a way that's respectful of the autonomy of these nations and their members. And so we spent a lot of time talking with them how to do this, and also trying to share with them how the goals of the study and how we hope to be able to give data back that again these nations can actually use as they make their own decisions about how they respond to the pandemic. And so as we think about this, we'll almost surely be need to do some oversampling in this. So we'll identify census tracts that have large numbers of the members of these tribes, and we'd like to be able to go there if we can work all this out and provide a useful sampling for these populations. As I mentioned, we spent a lot of time talking with American Indian Health Commission and others. We plan now on actually going and actually getting IRB approval from the Northwest Indian Health Board for their participation in this study. Not that we want to add levels of complexity, but we get strong feedback that this would encourage participation and give this a sense of legitimacy beyond the approval at the University of Washington level. The rest of the study is being done under a public health exemption, so we'll be actually going to them. Okay, so then we get down to the level of the households. If you think about Casper, other things, usually the field teams go and they look and they make sure that if there's supposed to be a house here, it's really there, and there's a household. Then we want to go into the individual household. We consider the household the unit. So ideally, we will seek to enroll all members of that household, all the adults, if they consent, as well as participants under 18 years of age, if there's parental or guardian consent in the younger person assents as well. We would like to include them in the study just to get the most robust sample possible. And spending a lot of time thinking about confidentiality and so forth. We spent a lot of time actually on the questionnaire. So what goes into this? What do you ask these people? We're not only testing them, we want to know something about their situation. Casper is only 2 pages. Our questionnaire is quite a bit more than that. We have a lot of questions around demographics. How do you identify yourself racially? Are you working outside the home? How often do you go to other places? Have you had symptoms? What are your exposures? Just what's your knowledge of COVID-19 and this disease? So all these things we want to capture, ideally so that our data set is as robust as possible to identify, again, risk factors that may correlate with higher COVID prevalence and identify places where there might be public health interventions that can be useful. I mentioned this, so again, we'd like to get the children in here. I think I'll just skip all that over. So it looked like this. So essentially, we are identifying these randomly sampled addresses. The participants are then invited to fill out an online questionnaire. If people don't respond, we'll try to follow up. And then ideally, we will set up a mutually agreeable time where we can either meet in the household or in a very local site for these individual census tracts for efficiency. And we will likely have some of a hybrid approach there. And then get, again, the sampling as well as the current symptoms assessment. This is going to be a challenge logistically, and we've done mapping of how much time our field team is going to need to drive to various census tracts. So these are maps in the colors. You can see where you can get in an hour. This is going to be a challenge, and we have a number of field teams scattered throughout. We've actually added. This is not quite up to date. We now have a total of 8 field teams scattered throughout the state. And again, as I mentioned, we hope to augment those with local assistance to the degree that it's available. Again, there is a longitudinal component to this. And ideally, we want to keep the same people in the study. So there is a progressive incentive structure that encourages people to come back for the second, or to participate in the second sampling and then the third sampling. We're well aware that there will be some dropout, and so we have a plan to replace individuals. It'll be complicated if some individuals repeat and others don't. We've talked about that with the statisticians, and that is addressable. And then we have a design to select new households as well. So when is all this starting? The first round of sampling is November, December. So the field teams have largely been assembled, and we are just about ready to go. So November, December should be wave 1. That's the fall wave of sampling. The winter wave of sampling will be January, February, and then there'll be spring, March, April. Whether we go beyond that and do later evaluation will be something we'll talk about through the coming months. So that sort of describes the study. I want to leave you with just a couple of thoughts, and then we'll wrap up. So these are general and not specific to the study. We're seeing more and more demand for testing. It continues to grow. As a program, we spent the summer really bulking up our capacity, and we haven't really been stressed too much yet. But as you know, we are in the midst of a third wave, and I do not yet see signs of it abating. So we don't know how bad this is going to get. We can do a lot more testing than we're doing now. It's not infinite, but I think we can do a lot. We've never seen a huge growth in demand for serology. I kind of thought we might. I suspect we may see more as now we have data that antibodies do protect you, and especially as we start to think about who should get a vaccine and so forth, there may be more demand there. I probably don't need to tell this group, but I will make this point because there's a lot of confusion. I hear a lot, oh, well, now we've got these drugs. We've got remdesivir, and we've got dexamethasone. And the therapeutic pipeline is not certain. As you know, people get diagnosed late. And then, of course, there's this huge immunopathologic component to the illness. And so, the drugs we have might get some people out of the hospital a little bit sooner. They might reduce your risk of dying of COVID-19 a little bit, but they're not perfect. And, I've heard people make analogies of these to HIV drugs, and, those are great drugs, and they really stamp the virus down. The drugs we have now are not that, and I'm not sure we're going to have those in the near future. Conversely, the vaccine effort is going well, I think. We are actually a major part of that. We're doing a lot of testing in support of those trials. And I think we're moving along, and I think we're going to see some data pretty soon. I hope it's positive, and I think that we are on track to get some vaccines out here, hopefully starting early next year. So with that, I'll just thank my co-investigator, Mark Wenner from the university. I mentioned Shell Dietrich, who's the program coordinator, is just doing a fantastic job with this. Paul G. Allen Family Foundation has funded this. Our partners at the Washington State Department of Health have been fantastic. And then so many collaborators within the University of Washington, Fred Hutch, and elsewhere. So with that, I'll stop. Thank you for your attention, and I'm happy to take any questions.
I hope all of you will join me in a virtual round of applause for Dr. Jerome. Thank you so much for a wonderful presentation. Please use the question box to ask your questions. And while those are coming in, we do have a few questions that were submitted earlier. The first one was, how much faster can results be delivered with sample pooling as compared to a traditional testing method?
Yeah, so the pooling probably adds, well, for the negatives, it doesn't add any time. It's negligible. All the pooling is done via automated robotics in the lab, so that might add half an hour. It's pretty negligible. Of course, if a pool is positive, we have to physically go find those primary samples. Now we have a system for that, so it's not like we're wading through thousands of tubes, but we do have to do that. And then they need to get retested. So we've spent a lot of time trying to make that as effective as possible. We tend to do those repeats on our fastest platforms, just so that we can get that done rapidly. But yeah, it probably does add about 5 hours of lab time for a positive.
And on one of your slides, you had a map, and one of the overlays was, it says, the question is, how is the lack of internet or dial-up internet only affecting your sample?
Yeah, it's something we've been concerned about, and so I mean, there's a couple of considerations around that. One is, lack of internet or broadband makes it harder to respond. We would like to do as much of the questionnaire ahead of time as possible. In our perfect world, people would have all of those questions done when the field team shows up at the door, and we can just confirm that and get the sample and move on. We're well aware that we will need to help some folks through that. So we're concerned about introducing bias in the sample just for those people. It may be a hard thing to get around, quite frankly. Geographically, we will continue to work harder to get the full sample from areas that as a whole have lower internet connectivity. But within that region, we may still end up oversampling for people who have more connectivity in every way or simply more plugged into the healthcare system. That's an extremely hard thing to get at. We'll capture some hints of that through our questionnaire of again, internet access, which is part of it, and educational status and so forth. But to some degree, these are parts of the issues that I think we've seen with polling for the election. Why are we still struggling with that? I think there are real differences in our country that we're having a hard time completely getting our head around, and I certainly don't have all the answers.
If someone tests positive for antibodies, will you be able to look back and estimate when that person was infected? Do antibodies for the virus deteriorate along a predictable timeline?
There's some data, yeah, that's a great question. So there's some data out there that suggests that depending on the platform one uses, the decay rates, the average decay rates differ a bit. So although the primary analysis here will be done on this Abbott platform, we actually intend to evaluate these samples on other platforms as well to see whether that's true, that decay rates are different. So there is an average decay rate for a given individual. Of course, it doesn't need to follow that perfectly. There's a pretty substantial difference between individuals. There's also a big difference in how much antibody an individual makes. So generally, people who have more severe disease make more antibody. Not surprisingly, they've been exposed to more antigen their body is making. They have to make more antibody to fight it off. People with very mild COVID generally make pretty low antibody responses. Some of those people actually become negative by some assays pretty quickly or undetectable. They probably still have some antibodies just below the limits of detection. So I don't think for a given individual we'll be able to say from a laboratory test when you had COVID. That is something that we're, again, trying to capture in the questionnaire, which is, have you had COVID-like symptoms, and if so, when? And it'll be interesting to see whether we can get any meaningful correlations out of that, given the potential differences in decay rates, the differences in just magnitude response, and then people's incomplete recollection of when they had symptoms.
So that is all the questions I have on my list. I want to thank you again for presenting this valuable research, and thank you to everyone for participating. These presentation slides and the CME evaluation will be available on our website, and please remember to complete the evaluation to receive CME credit. There's a lot of pouring in. Oh, actually, we do have time for one more question. Anna, do you want to go ahead and let's see. So Anna just followed up with her previous antibody question with, given that antibodies decay rapidly for people with mild infections, are you concerned you might not capture everyone who's been infected?
Well, that's certainly a possibility, and again, that'll be something that we'll be looking at with the questionnaires. Who's had COVID-like symptoms? There's really no way to know, quite frankly, and I think it's always a concern we'll have. Part of the reason that we want to use a secondary test is that the second test that we hope to use on at least a subset of samples has been reported to be more sensitive. It's thought to decay a bit more slowly, as well as be more sensitive. So it'll be interesting to see that if we get a correlation of people who report mild symptoms, maybe those will be overrepresented by having borderline positivity on the Abbott and a higher positivity rate on the second assay. Again, that's something we'll just have to see. But yeah, it's a very valid concern that we're quite likely to miss at least a few mild cases.
So thank you again, Dr. Jerome, and I hope everyone has a wonderful week, and remember to take care of yourselves. Have a great day.
All right. Take care. Bye.
Thank you.